Hello, everyone. Welcome to our three-part introductory learning series on early psychosis 101, basics for supporting students. We thank you for your interest in our learning session today. This learning session is presented to you through a partnership between the Mental Health Technology Transfer Center Network and the Psychosis Risk and Early Psychosis Program Network. We do have a few hundred registrants for our session today, so we will give everyone a minute to get settled in and we'll get started momentarily. I do want to remind everyone that all attendees are muted and off of video. Today's session is being recorded and will be shared with everyone who is in attendance today within a week. Again, for those who just came into the room a moment ago, welcome. Thank you for being here. This is our special three-part introductory learning series, Early Psychosis 101, Basics for Supporting Students. We will get started in just a few seconds. We're allowing for a few hundred registrants to settle into the room. I want to remind everyone that all attendees are muted and today's session is being recorded. The slides and the recording will be shared with all attendees within a week. And Steve, would you mind letting me know if you can hear me okay? I see a note in the chat box that I'm cutting out a bit. I just want to confirm. Can you hear me okay? Okay, great. I'm getting a thumbs up, so I'm going to officially kick us off here. Thank you so much, everyone. Let's go ahead and get started. Today, we kick off session 1 of our three-part learning series. We'll be focusing on recognizing and responding to signs of risk for psychosis in students. We have about 60 minutes together today, and we're really excited to share this space together with you all. On the next slide, we have a few reminders to help everyone get settled in. Again, I've said this a couple of times, but this webinar is being recorded and will be posted with slides to our MHTTC website within a week from today. You'll receive that notification via email. Participants are muted with their video off today. You'll see in the Zoom toolbox at the bottom of your screen that we've enabled the chat box so that you are able to share comments with us or let us know if you're having any tech issues. We welcome you to use the Q&A box for any content-related questions for our panelists. And you are welcome to click the CC icon, the caption icon on your Zoom panel if you'd like to enable captions. Again, the session slides, the recording, certificates of attendance, all of that will be sent to you within a week. And a reminder that this session does not offer CEUs. So a little bit about the MHTTC network. For those of you who have not worked with us previously, this series is brought to you through a partnership between the Mental Health Technology Transfer Center Network and the Psychosis Risk and Early Psychosis Program Network. The MHTTC network is funded by the Substance Abuse and Mental Health Services Administration, also known as SAMHSA. And the purpose of our network is to accelerate the adoption and implementation of mental health related evidence-based practices. We have a school mental health initiative, and through that initiative, we bring awareness, disseminate information, and provide training and technical assistance on the implementation of mental health services in schools and school systems. We invite you to learn more about the MHTTC network by visiting our website, mhttcnetwork.org. On the next slide, we have a bit of information on the Psychosis Risk and Early Psychosis Program Network. I'll be passing it over to my colleague, Dr. Steve Adelsheim, who will share a little bit about PEPNet and then a brief overview of why this work is important. Steve?
Thanks, Jessica. And thank you all for being here today for this really important topic. And we'll talk in a minute about why it's so important that you're here, but quickly, I'm Steve Adelsheim. I use he, him pronouns. I'm a child psychiatrist at Stanford with the Center for Youth Mental Health and Wellbeing. I'm one of the co-directors of PepNet and also involved in other work related to early psychosis. Just, quickly to share with you, PepNet really is a network supporting clinical efforts related to clinical high risk for and first episode psychosis. We also work as part of the MHTTC network as well, and are really grateful to Jessica for her support and Judith Doberman, who works with us on PepNet, for their support in bringing you this series of presentations focusing on early psychosis, really for our partners in schools and in education. Let's go to the next slide. This work is really critical because of your role in terms of recognizing and linking young people with early psychosis. In the United States, generally, the time it takes to identify people who have been facing and dealing with an issue of psychosis is often up to 18 months and longer, whereas in other countries, it can be down to 3 months, 90 days, 100 days. And that's because in our country, we often don't have the awareness and early recognition of young people when they're addressing and facing issues of potentially clinical high risk or having psychotic illness, which is why we felt it really important to do these presentations for you. And we're really grateful that you're here. Let's go to the next slide. What I will share with you is that this whole early psychosis effort has been an expanded priority within the United States for the last number of years. Every state receives some funding in their mental health block grant to support early psychosis efforts. There's been additional funding through COVID relief as well to support this. And this model of coordinated specialty care has really taken off across the United States. And SAMHSA, actually, the Substance Abuse and Mental Health Services Administration, just recently funded a new training and technical assistance for early serious mental illness that incorporates support for those at clinical high risk for facing a first episode of psychosis. Next slide. What you can see is that we have really grown in the last 10 or 12 years to really quite a few programs. And now this number in the US is closer to 400 programs for early psychosis across the United States. And it might be helpful for you to be aware of where those programs are within your community. You can go to the PepNet website and take a look at our map and find the program supporting those with early psychosis experiences in your community or the closest ones to you as well. Next slide. There's also a large research network that is supported through the National Institute of Mental Health called EpiNet, which is also partnering with over 100 programs across the country, doing coordinated research efforts to support young people with early psychosis-related issues. Next slide. So I have the honor of introducing our wonderful speakers for our session today, and really grateful to them for their participation. First, Michelle Friedman-Yakubian, a licensed clinical psychologist in Boston, co-director of the Early Psychosis Working Group of the Mental Health Technology and Transfer Center Network, and a trainer for the New England MHTTC. Dr. Friedman-Yakubian's career has really been devoted to the development and implementation of effective psychosocial interventions for individuals experiencing psychosis or signs of risk and their families. She co-founded the Cedar Clinic, the first clinic for youth at clinical high risk for psychosis in Massachusetts, and also is the associate director of a clinical high risk for psychosis community program grant focused on expanding early interventions for psychosis across Massachusetts. She's also a principal investigator in the Response to Risk program at Beth Israel Deaconess Medical Center, with a research program focused on developing school and cognitive interventions for youth with CHRP, clinical high risk for psychosis. Dr. Friedman Yakubian is also an assistant professor in psychiatry at Harvard Medical School and earned an undergraduate degree in human development and family studies at Cornell and a doctorate in clinical psychology at UMass Boston. Our other guest is Vera Muniz-Sarré, a non-binary queer Peruvian public health professional currently working as a program coordinator and peer advocate for the Massachusetts Psychosis Prevention Partnership and building bridges toward equity in psychosis intervention and careers grants, also at Beth Israel Deaconess Medical Center, and a peer counselor at the Lab for Early Psychosis at McLean Hospital. Vera is diagnosed with schizoaffective disorder, a survivor of conversion therapy targeting their sexuality, and identifies as MAD and a psychiatric survivor. Starting in 2017, Vera helped found and administer the Psychosis Spectrum server on Discord and still helps maintain that community. Vera graduated with her Bachelor of Arts in Psychology and Master of Public Health and Community Health Sciences from Boston University. So thank you both for being our speakers today. We really look forward to learning from you. So let me hand things over to you.
I moved my mute box. Awesome. Thank you so much for having us. And I am so appreciative of the opportunity to speak with all of you and really appreciate that you are taking time out of your very busy lives to learn a little bit about recognizing and responding to signs of risk for psychosis in students. So we're going to jump right in. And as I'm doing so, I just want to encourage folks to be brave. Put your questions and ideas in the chat. I love that folks are introducing themselves and I have a sense of where people are and different times of day. It's just really nice to have a sense of who's out there. So we're going to talk a little bit about the importance of your role working with kids. It looks like we have a lot of folks who work in schools and also folks who work in clinical programs. We're going to talk a little bit about a case example, a little bit about what are the early signs of risk, and a very brief introduction to talking with students and families. You'll be getting a lot more about that in next week's or the next session that's coming up. I know you all lead really busy lives, so in case you get called away for an emergency and you miss the bulk of this talk, I just want to start with some of the take-home points, so things that I hope you'll remember. Number one, I want you to leave this talk with the knowledge that psychosis is treatable, especially when symptoms are recognized early. Psychosis is a lot more common than you might think. It's definitely a lot more common than a lot of the young people, teenagers, young adults that you may interact with might realize. It's on a continuum that we're all on. You might be the first person to recognize signs of risk, and the early symptoms are often easy to dismiss. And your role with kids and how you respond can make a huge difference in helping a young person to get the early helpful support that they need. Here's a little bit about what high school students, and certainly anyone who works with high school students, is very familiar with and aware of. And you play an incredibly important role, especially folks who work in schools. You spend a huge amount of time with kids. You have a good idea of what their social context in school is like, and you might be, especially anyone working as a guidance counselor, adjustment counselor in school, you might be the first point of contact that a young person might have with the mental health system. And so your ability to provide a supportive, helpful, confident response when a young person comes to you and describes their experiences can make a big difference. We hope that you'll feel a little bit more confident in that after participating in our series. I'm going to turn things over to Vera for the next part.
Hey y'all. My name's Vera. Nice to see y'all. Or I guess nice to be seen by y'all. And I guess we're gonna start off with a little case example here of a student that we're following named Jess. This is a composite case example, so like this is not a real person. But Jess is a 16-year-old non-binary student, and within the last 6 months, Jess's grades went from A's to D's. They stopped attending their extracurricular activities. Sometimes they hear whispers no one else can, and they have seen some moving shadows in their vision. They wear headphones constantly to help manage their discomfort with being in large groups. And they report feeling uncomfortable in crowds due to due to fear of people knowing their thoughts. So if you want to take a quick screenshot or snapshot of this slide to just remember the details of the case example, that's fine. But I'll just give you a second. But in the next slide, I'm gonna ask y'all to do a bit of a chat waterfall activity. So I'm gonna give y'all just a couple minutes just to type down your thoughts, and I want you to just write your responses in the chat box without hitting enter. And when on the count of three, I would like you to just just tell everybody in the chat what you think could potentially be going on with Jess. But I'll just give y'all like a minute or two just to write your responses, and then after that, we'll come together and look at what y'all thought. Looks like I'm already seeing the chat start waterfalling, so I can start. Let me go towards the top of the responses so I can start seeing what people have been saying. Um, so I'm seeing some potential signs of depression is what people have been saying. Somebody mentioned drugs, trauma, or a mental health episode. Um, I'm seeing trauma and depression coming up a lot. I'm seeing potential psychosis or drug use being mentioned. I'm seeing depression and isolation. Um, I'm seeing responding to external stimuli. Yeah, definitely. People who experience psychosis sometimes can have symptoms that react to external stimuli, and so as a result, may have that happen as well. Maybe some prodromal symptoms. I like that language. Although we're talking more about like clinically high risk now in the field nowadays, as a more of a concept, more to describe that concept of like the onset of symptoms. Um, Medical substance use related depression with psychosis, auditory and visual hallucinations. Yeah, definitely. If they're experiencing some visions or shadows, that could be something that they are experiencing. Definitely seeing a lot of overwhelm, stress, anxiety. Um, and yeah, it seems to be a lot of the trends that I'm seeing. Um, I did see some people actually use the word CHRP, which I can appreciate that. So clinically high risk, because we'll talking a little bit more about that later in the presentation as well. Awesome. Yeah, these are all good initial instincts and responses to what Jess could be experiencing. Um, I'm seeing some other questions and follow-up questions too. So that's also something we'll talk about. That context is super important, and asking follow-up questions is critical when figuring out if somebody is experiencing CHRP symptoms. But just for the next minute or so, I want to focus on the second question. And if you could type in the chat, what typically happens at your school when a student discloses concerns like this? And I'll give y'all a couple minutes to respond to that as well. Yeah, I'm seeing a lot of referrals to therapy. I'm seeing calling the counselor. I know there's a lot of clinicians in this presentation in this audience as well. So I can imagine that a lot of y'all are the first response that a lot of children will be encountering. I'm seeing like call me, yeah, therapy referral to wellness center, contacting parents, definitely. Helping family connect with students or psychiatrists. Depending on your context, your interactions with their different supports may be different, and the capacity to which you interact with them may be different as well. So, like in a school setting, you may interact a lot more with the student directly and with their community members, and like see the sources of support that they're seeking from their peers. Whereas, like in a more clinical setting, you may have more access to their parents more directly. Um, and yeah, I'm also seeing like community-based supports and referral to behavioral health treatments. Yeah, those are all some good initial instincts. Um, but I guess we can move on a little bit to talking a little bit about psychosis as a concept. Um, Psychosis is not a diagnosis, and I think that that's something that we need to establish very clearly initially, is that psychosis is a set of symptoms referring to a loss of contact with what we call consensus reality, or difficulty telling from what is real from what is not. The concept of consensus reality, I think, is very foundational to understanding psychosis as a concept. And like people don't always like the term psychosis, and like individuals will use different terms to refer to their experience, like voices and visions, and altered states is another thing that's gaining traction in the activism scene. But consensus reality refers to the culturally agreed upon concepts of reality in a group of people based upon their own common experiences and cultural background. And this will be different from cultural context to cultural context. Um, and a person who experiences psychosis in the context of drug use or medical use, or medical issues such as seizures or sleep deprivation, or in other mental health problems such as schizophrenia, bipolar disorder, or depression. Something that one of the researchers that I work with often says is that like we often give the label of schizophrenia to people who experience psychosis when we don't know any other biological or like physiological cause, and that we can only link it to their mental state. Psychosis as a concept and as an experience is overlapping with a whole lot of different biological presentations, as well as like interactions with like pathogens, and can be a result of any number of different things, and it's not necessarily just related to schizophrenia or bipolar or other forms of like what we would label as psychopathology. So, someone who experiences psychosis may experience some very common challenges, namely cognitive challenges. And we usually think of the modalities of symptoms as being like positive symptoms, negative symptoms, and cognitive difficulties. And those I think can kind of obscure the point a little bit, because I think that like positive and negative isn't always like intuitive what it means. And if it's very much an industry term, so if you don't know that positive is referring to added experience and negative is referring to like taking away from the experience, it can kind of obscure what those terms actually mean. But some of the main issues in terms of cognition that we're thinking about is like confusing what is real or imaginary, feeling sort of suspicion or paranoia, trouble organizing speech or behavior. There can be any number of like um, disorganized speech or behavior presentations depending on the person, and namely also trouble with perception. So hearing voices or whispers that others can't, seeing shadows or figures, or different changes in hearing or vision that may appear as like distortions in how people are perceiving the world. There can also be things like trouble with motivation, like diminished drive to socialize, or like feeling like they're withdrawing from their social activities, any sort of extracurriculars, even like friends and family. And in terms of like cognitive challenges, they can happen on any sort of cognitive modality. So memory, attention, language, perception can all be affected in various different ways based on the individual and their own personal experience. And so I'm going to pass it off back to Michelle so she can talk a little bit about the continuum of psychosis, and progression as an experience.
Awesome. Thanks. So we're doing a little bit of a whirlwind introduction to what is psychosis today. It's going to serve the basis for some of the upcoming sessions as well. But one concept we want to share is this idea of psychosis as being on a continuum that everybody is on. So at the very mild end of the continuum, we have experiences that that may show up in most students that you know. right? Person has still has reality testing intact. An example might be, I think my classmates don't like me, they talk about me. I think that's a pretty common concern that can come up for a young person, but usually doesn't cause a whole lot of challenge in any way that's unusual for them. At a very high end, we have what we might call full psychosis. So the experiences are so compelling that it becomes hard to tell what's real and what's not real. Person believes 100%, for example, there are spies in my school who are stealing my thoughts and putting them on the dark net. At this very high end of the continuum, person may be very preoccupied with that idea, and it's causing a lot of challenge. And then in the middle, we have what we might call moderate, or this is the area that Vera had mentioned earlier, might be called clinical high risk, or and in this sort of moderate area, a person is experiencing some thoughts, experiences that are confusing to them, they bother them, but there's still an intact ability to doubt or wonder what is really going on. So an example of this might be, my teacher might be reading my mind and recording me. And really the big picture that we want to point out is that people can move from one end of this continuum to another. And a lot of the goals of early intervention, those of you working in schools and in touch with young people, have a real opportunity to try to connect with kids when they're in this kind of moderate area in order to prevent the symptoms from getting more significant. Also, just want to point out that psychosis is a lot more common than you might think. 3 out of 100 people, that's 30 out of 1,000 high school students, will experience a psychotic disorder at some point in their lifetime. And as many as 7%, or 7 out of 100 high school students will experience signs of clinical high risk. So these symptoms are a lot more common than often people realize. And we are learning more and more from research that early intervention is possible and can promote recovery and prevent disability. We're so excited about working with folks who are in touch with high school students, because we know that half of all adult mental health disorders start by age 14, 75% by age 24. And the early symptoms are often hard to recognize. And it makes it hard for kids to get the early support and treatment that could be helpful. We know that early treatment can make a difference for young people. This is a very complicated slide, but basically along the bottom, we have age, up and down, we have kind of health status or level of functioning. And in a lot of standard care for psychosis, unfortunately, the first point of contact, or the first treatment, this big yellow ball here, or orange ball, I don't know why I say it's yellow, is often in an emergency setting, which is really unfortunate. It's almost like, if you think about this as a physical disorder like cancer, it'd be like waiting until someone's in stage 4 cancer, needing emergency intervention in order to begin treatment. And unfortunately, when people first have their treatment in the emergency room, they can often experience some recovery, but they may have subsequent episodes and challenges that really impact functioning. With early intervention, identifying people at clinical high risk for psychosis and intervening early, the hope is to be able to prevent the symptoms from getting to the point of full psychosis, to prevent the need for emergency intervention, and help people stay on track. As Steve mentioned earlier in the introduction, unfortunately, the average adolescent may experience psychosis for more than 18 months before they get treatment. And 60% of psychotic disorders are diagnosed in crisis settings. We know that delays can lead to poor outcomes, including functional and cognitive impairments, increased risk of suicide, and losses in social and role functioning. And this is why your role is so important, because you might be the first person to see warning signs. And we know that with timely help, recovery is very likely. There are often a number of barriers to treatment. In the interest of time, I was going to do a chat waterfall, but I think I'm just going to kind of go through and share some of these as well. I think folks will often cite stigma. People are very concerned. A lot of times folks are experiencing confusion, shame, worry about themselves when they are first experiencing symptoms, and it can be very hard to reach out for care. There's a lot of ways in which the folks who are experiencing psychosis for the first time are often not in much contact with the medical system, and maybe in a position of having very little privilege, very little sense of being able to talk with doctors, talk with adults in their lives about experiences they're having, and to feel like they're going to have a good sense of being able to get the help that they need. Another one I just wanted to mention, and also as I'm talking, if you guys have ideas about other important barriers, please mention them in the chat and reach out and mention them as well. What I wanted to address is that very often when I have the opportunity to talk with clinicians who work in high schools or in general clinics, I often try to get a sense of how comfortable people are asking about or screening for psychosis symptoms. And very often when folks learn about psychosis in graduate school programs, teaching programs, they learn things like psychosis is kind of hopeless. People don't get better. And that can lead to a lot of kind of reluctance of clinicians to even ask about symptoms. And one of the things we really hope this series is going to help you all with is to have a sense of hope and to recognize that there are lots of options for kids that are experiencing early symptoms. And thanks. Lots of folks mentioned trouble with insight, different kinds of, cultural, and we'll sort of come back and talk about ways in which I think talking about culture is sort of an important point, because sometimes psychosis symptoms can be under-recognized or over-recognized due to sort of cultural differences and lack of understanding between adults and individuals who are experiencing and talking about their experiences. Now I'm going to point things back to Vera for the next section.
Hi, Al. I guess so it probably won't surprise you to realize that Jess is not a real person based on the stock photo images. But it may or may not surprise you that the information that we gained actually came from my own personal experiences. So I just wanted to give you all a little bit more of my background and my story a little bit. In terms of like my experience both in the field and like as someone with lived experience. But hi, all. My name is Vera Muñiz. I use they, them, and ella and ella pronouns. I am a queer non-binary Peruvian person of mixed Spanish and Andean ancestry. And I am currently with the M3P program, Massachusetts Psychosis Prevention Partnership, and the Building Bridges for Equity and Psychosis Intervention and Careers grants at Beth Israel Deaconess Medical Center. And I'm also a peer counselor with the LEAP Center at McLean. And I definitely feel that like my ability to like access a lot of academic structures is giving me a lot of privilege in being able to like describe my own experience as well as affect like the material conditions of like how I access treatment and where I can get treatment from. But I don't think that that was something that was consistently available to me throughout my treatment journey or throughout my mental health experiences in general. Growing up, my family never really talked about mental health in any capacity. And we kind of swept everything under the rug. We try to make sure we weren't like saying anything publicly. It was seen as something very shameful to talk about, like in something that would damage the family reputation in any capacity if we would talk about it publicly. And that was until my parents found out that I was queer and they started taking me to conversion therapy, which ended up definitely shifting. It definitely shifted how I thought they viewed mental health in a larger capacity. And it made me feel very unsafe talking about my experiences openly, even to people in my own family who were my only access to care, especially when I was in high school before I graduated. I had a lot of paranoia and preoccupation with death and like my safety as a whole from very early on growing up. It was a very frequent thought that like everyone wanted me to kill myself. I started hearing voices and seeing shadows in high school. Around the time I had my first psychotic episode, between my sophomore and junior years, I definitely noticed that there was something happening. But talking about it openly was very difficult. I had an ex who I remember like confiding in about the experience. And I remember his response was, "That doesn't sound very much like depression. That sounds like schizophrenia." And then I immediately never talked about it ever again until after I started seeking treatment again in my undergraduate years. Um, I didn't really want to say the word schizophrenia or psychosis. I thought like they were dirty words. Not like literally, but like they felt like they were taboo to say, or that would in some way be used to like deny me autonomy. And that was really the main thing that like kept me from seeking out services, is that admitting that I was experiencing any of these things felt like it would be opening the doors for having my autonomy to be like denied to me. Um, and that really culminated in my first hospital stay, my first inpatient hospital stay, the only one I've had so far, knock on wood, that I had in my first year of undergrad. After a particularly stressful year, I went in as a pre-med neuroscience and psychology major, made it out with just my psychology degree, which I'm very proud of. But those additional stressors of the program that didn't feel very accessible to me were very noticeable to me, and kind of made it to a point where I was like avoiding classes. I didn't want to be in crowds. And there was actually a final exam that I ended up missing because I thought that my professor wanted to hurt me. And that I ended up failing a class that ended up affecting my GPA in undergrad. Um, so that entire experience was very unpleasant. And inpatient was even more so. That like there was an experience that I remember with a fellow client who ended up punching a wall and like injuring herself, and who wasn't able to get care, even though the rest of the clients on the floor were trying to ask for help because the doctors were all having a meeting and the orderlies did not want to disrupt the doctors. So I think that that was very much a tone setter for like when I started seeking care. In high school, um, I definitely don't think I had the capacity or the tools to even name my experience. Um, and once I started getting to undergrad and like actually learning about mental health in like an academic capacity, I felt that it was like I was doing my own psychoeducation. I was teaching myself to describe my own experience, without really realizing that was what I was doing at the time. And I do think that had I had those tools earlier on and not behind the barrier of like the cost behind like a higher education, uh, I think that that would have been much more helpful to me figuring out my experience. Um, I didn't really have any community to talk about psychosis with at all until I started a chat server on Discord online in my undergraduate years. Um, and it's still running today. Love the community, still have friends from there, and like we still talk. And it really gave me my first sort of taste of what peer support was like. And that kind of sort of has shaped me in terms of like how I want to approach the mental health field. I very much am a proponent of peer support. I'm a peer counselor, and I'm in the process of getting my CPS certification, Certified Peer Specialist certification. And I really do think that like the future of the industry is in peer support, both on like a youth level and like just a general mental health access to services level. Um, and I think that the one thing that has been cemented in my mind about the systems that I've had to both rely on and had to be a part of, is that they're not inherently built to help people like me. And I have a lot of intersections of privilege that allowed me to access the structures that I was able to access. But there are many situations in which like I could see myself not having gotten to like college at all, or not having gotten to the treatment structures that I wanted to in Boston because I didn't know that they existed. Nobody really redirected me to any psychosis specific resources until I actually started looking for them myself. And then I found the MapNet website online, which is a great resource if you're in Massachusetts. The MapNet website has like all of the psychosis specific first episode psychosis and clinically high risk resources in the area. And it was life-saving for me in terms of finding like competent care that I thought was uplifting. I definitely would have benefited for more accessible interpersonal and community supports. I do think that like having people to talk things over with and have who had common experiences would have been much more helpful if I had accessed it earlier on. I didn't really have any redirection to resources, and on a basic level, I don't really feel like I've had very much compassion, both from my my school community and staff, as well as like from like the clinicians that I was seeking care from. I felt like there was really like not very much confidence in my ability, and that there was sort of like this fatalistic tone that people often took when talking to me about my symptoms and like how how it would impact my functioning. And I do think that what ended up doing the most harm was sort of the loss of autonomy, or the fear of the loss of autonomy that I would experience if I was ever to like be fully open about my experiences of like experiencing suicidality or self-harm. And ultimately, I think that led to a lot of isolation and both internal stigma as well as like discrimination from my peers, kind of kept it, and from treatment structures ended up kind of making it so I didn't feel safe doing so. um I feel like being more open and willing to talk about psychosis, even on like a casual level, even outside of treatment or peer support structures, I think would also have been super helpful. And also like I think that acknowledging the harms that mandated reporting can sometimes introduce, when we're thinking about like people who are experiencing abuse not feeling like they can talk openly about it. Because first of all, I lived in Florida, so conversion therapy was legal. And even if I had had legal support, there was a risk if they determined that my family was being abusive, that I would be removed from my home, which would derail my entire academic and professional plans and potentially keep me from accessing further supports in the future. So I think that that is all like very much where the direction of the field needs to be headed, is like addressing those shortcomings. But in terms of, if you have any questions about my experience, or if you want to connect more about like accessing and equity in terms of like representation in the treatment community, talk about you can reach out to us about the 2B Epic grant and ask us about like our work there. But we'll have like a little bit of a Q&A period after this. But I'm gonna just go ahead and pass it back to Michelle.
Thank you so much, Vera, for sharing your experience. I've learned so much from you, and your bravery in sharing, and you know, going from a journey of being really scared to talk about your experiences to being very open and generous, and so many people have the opportunity to learn from you. So I hope you can see in the chat there's lots of appreciation coming your way. So I'm going to run through a bunch of information very quickly so we have time for questions. We will get a copy of these slides, and I am happy to chat with you about questions that you have. So I'm just going to skip through. This is a little bit about the concept of identifying and really responding to some of the earliest signs of risk for psychosis. There's advances in the field and assessments that allow us to do this in a much more nuanced way than we have in the past. There's also a number of kinds of treatment that have increasing support for being effective. And we do know that the earlier the treatment is started, the more likely it is that non-medication psychosocial treatments can be helpful. So when young people are experiencing those mid-range experiences where they're still able to have some insight and doubt or wonder about what's happening, then family, individual therapy, school support, skills training, and peer support make a big difference. When symptoms get more pronounced and a person winds up having a really hard time telling what's real and what's not real, almost always medication winds up being an important part of the treatment, can be very helpful. But one of the potential advantages of early intervention is to reduce the need for medication. Here are a few examples of the kinds of experiences that are associated with risk for psychosis. Some of these experiences are incredibly non-specific and are probably present in all of the kids and young adults that you know. these ones on the left. Some are more specific and related to early psychosis. If a person does have a close relative with psychosis, that can also, we do know that psychosis can run in families as well. And any of these kinds of experiences that are new, getting worse, can be meaningful. Here are some examples of ways that you might consider asking about psychosis. We do tend to find a lot of folks have been asked questions like, do you ever have unusual thoughts that other people find or can't understand? And it's kind of a judgmental way of describing this. So I have a colleague, Barbara Walsh, who really shares these kinds of openings that can just open a door to talking with a kid about experiences. Next time, you're going to learn a lot more from our presenters about screening tools that can be helpful. I've also included just an example of what some follow-up questions. I think one of the things that you talked about, Vera, that was really important was how people responded to you when you described your experiences. And I think it's really important to, if a young person trusts you with experiences that they're having, to be very open-ended, non-judgmental. Try to understand the social context that they're experiencing and don't jump to conclusions. This example is deliberately very vague. I think my house is inhabited by spirits may or may not be something that would be related to psychosis. This could be a cultural belief that is something that's very well integrated in that person's subculture or culture, or it might be a sign of risk. So the next session on November 1st is going to provide a lot more information about how to screen for psychosis, and also what are some of the kinds of help that can really make a difference for kids that might be returning to school after an interruption caused by psychosis symptoms. In short, if you are someone that a young person trusts with experiences that they're having, and they talk with you, that they feel like their mind is playing tricks on them, I hope that you will feel empowered to respond with hope. Let the person know that you really appreciate them trusting you with the information, letting them know there's help. It's more common than you might think, and that early intervention can make a difference. And lots of resources have been shared and can be found on the PEPNet website to find out more about early psychosis and clinical high risk for psychosis programs in your area. And again, here's our take-home points. And now we will stop for some questions.
Thank you both so much for a wonderful presentation. And Vera, especially thank you for your wisdom and courage and sharing your experience and your expertise with all of us. We're really grateful. And Michelle, thank you for sharing your clinical knowledge and guidance around these programs. And thank you all for your questions and for your attendance today. We have a few minutes to address some of the questions that have been raised. So let me try to, for Michelle and Vera, summarize just a couple of them. Some folks are asking, how young actually should we be looking for young people to maybe be expressing some of these symptoms? And then also, can they start when people are also older as well? I wonder if you both could maybe speak to those questions initially.
Sure, I'll take a quick stab. So it's rare to see these kinds of symptoms in very young kids. Most of the programs that specialize in working with kids at risk for psychosis start around age 12. So fairly young, but not young. When you see really, really young kids, and actually we can probably post in the chat, we have some colleagues in Pennsylvania that have put together a flow chart for thinking about kids that are under age 10, where that can be confusing. The most common age of onset is teens to early 20s, though it is possible for some folks to develop symptoms later on. And sometimes people can develop symptoms of psychosis in later life due to other physical conditions that they might be experiencing.
I always think of like it's always possible for someone to experience psychosis at any stage of their life. And also it's probably most likely that they'll first be, if it's something that they are chronically experiencing, that they'll first experience it like teens or early 20s. But the human mind is flexible. So like I feel like it's one of those things where like there's never any definitive like 100% correct answer when it comes to like psychology concepts, I think.
So yeah, so that's really helpful. You know, some people are also trying to understand, um, you know, even as we talk about sort of definitions of psychosis. So some of the questions include trying to understand, you know, if, for example, one of the questions that just came up from Carrie, if an individual can't really differentiate what is real and what is not, and experiencing hallucinations, would that mean they have psychosis, or is it only really psychosis if it becomes a problem? For example, if the voices might be telling them to harm somebody or something like that.
I think it's partly based on self-identification of like how the person wants to identify or label their experience. Um, I I I I think that people who experience psychosis and people who experience hallucinations have similar experiences. And like, if we're going based on entirely a medical model, people who experience any level of hallucinations or delusions or like any difficulty differentiating between what is real and what is not are experiencing psychosis. But an individual's interpretation of their experience may be entirely different, or their cultural interpretation of the experience may be entirely different. They may not label it as psychosis. They may just think of it as like voices or visions. They may think of it as like the voice of God. They may be thinking about it as like ancestors telling them to like how to go about their day. And ultimately, how someone labels that experience is going to be entirely individual. I personally like the word psychosis for describing my own experience, but that is not the case for everybody with with those experiences. Um, and the term psychosis specifically, a lot of people have issues with because it does come from the medical model and comes from like pathologizing the experience. And some activists don't like that. Some activists do. It's very much like a growing discussion. But I think that it can. I think it definitely it's sort of the same discussion of like person first versus like identity first language, that the individual will be able to tell you what they prefer.
I agree. I think one of the things that when it comes to treatment for voices, voices and hallucinations tend to be most problematic for people when they feel powerful and the person feels like they have to listen to them and do what they say. And so treatment often really focuses on helping people to feel more empowered to either listen to the voices or not listen to them, and act on them or not act on them. And there is a whole movement of individuals who identify as voice hearers, who may or may not actually experience, when it comes to early intervention, it's not helpful to identify folks who are not experiencing any trouble based on those experiences. So there are a host of people who hear voices for whom it's not causing any trouble in their lives. And so if you're interested in that, hearing voices movement is something to learn a little bit more about. But most of the time, the kinds of kids that we'll see in our clinics are experiencing voices that are concerning to them, confusing, overwhelming, and hard to ignore. And that can be that can make a difference.
So thank you for that. You know, we have some other really great questions, but we really only have like 2 minutes left to answer them. So let me ask one, or two general questions from Emma, which is really around supporting either young people or family issues in relation to this. So Emma was asking, if parents aren't supportive around addressing these issues, how might you suggest that people working in schools sort of handle that situation? Or if a student might, mention having some symptoms or signs that seem like they could be warning signs, but they aren't ready to talk about them, what might be some next steps that people in schools could be thinking about to be of support?
I actually think this ties into another question. Somebody was asking, like I mentioned, peer support and being sort of the future of care. And I do think that this ties in very nicely. I think that like youth need people their age to be able to talk about their experiences and relate to. Obviously, we shouldn't be allowing like teens to be making like clinical decisions or like be making like clinical determinations that are super like potentially life changing. And yet the people who are like individually processing their experience have the most benefit when they're able to talk to other people who are their peers. So I think that there are organizations that like the Hearing Voices Network. There's Students with Psychosis. There's other peer support structures in Massachusetts. We've got like a couple drop-in spaces that are run by the peer certification nonprofits in the area. So I would very much encourage to seek out peer support resources. And if those don't exist, seeing if you can establish some in the school setting would potentially also be really transformative too.
And one thing I would add, because I know you guys are all working in a lot of settings where you say, that would be great. I would love to have that. But right now I've got this kid who's experiencing symptoms and the parents, they don't want this kid to talk to me. It's such a hard, I mean, you guys have such a hard job. And really the only thing I would say is to recommend that you really listen openly to the parents and try to think about and remember that the parents are doing the best they can. They, tend to want what's best for their kid and try to understand what is making them scared, what is sort of holding them back from wanting that kid to be able to talk with you, to get the support they need. It's a journey. It takes time. And anything that you do to kind of keep the lines of communication open, to make it clear that you really want to listen to their perspective, that your job is not just to tell them what to do. You want to listen to their perspective. You want to hear them out. You want to find common ground on, both of you are interested in trying to help the kid. That's the road that can lead there. But it can often be a really challenging one. And I really appreciate the question.
Well, thank you both very much. And thank you all for the questions that you've just put in the chat. We see them sort of increasing as our time is decreasing. And so let us think about how we can try to get answers back to some of you or address some of them in the next several sessions that are coming up. Let me thank you all for being here. Let me thank our speakers for your wonderful information and hand things back to Jessica to close us out.
Thank you, Steve. If we go to the next slide, I just want to share a couple of quick reminders with our audience here today. We welcome you to join us again on November 1st, same time as today. That's in 2 weeks. We have part 2 of the series. Part 2 focuses on empowering educators and screening for psychosis and navigating school supports for students with psychosis. A reminder that we will be sharing today's presentation slides and the recording, as well as access to a certificate of attendance with everyone who registered for the series within a week. We'll also make sure that these materials are available on our MHTTC website for everyone to access, whether you were able to join today or not. On the next slide, I just have a quick reminder about an evaluation that we are required to ask you all to please submit. It takes no more than 3 minutes, and this helps us continue to receive funding from SAMHSA to continue to put together trainings like the one that we've led today, free of cost. And so we would appreciate you completing this quick evaluation so that we can learn more about the quality of this event and continue to plan these types of events for you all free of cost. When you close the Zoom webinar window today, your browser will automatically pop up and the survey will be there for you to complete. I'll also make sure to access, to include a link for you to access in the email follow-up that we'll be sending in the next few days. And the final slide here, since you all will get a copy to the slides, we're linking you to our MHTTC network website, where you'll find several more resources around early psychosis in schools and in general for you to access free of cost. We also will link you to the PEPNet website so that you could learn more about PEPNet and access additional resources available, like I said, on early psychosis for students, for youth, and for the general mental health workforce. Again, thank you to Michelle and Vera for being here with us today and bringing this vision for this series to life. We really appreciate PEPNet for collaborating with us at the MHTTC Network to bring this learning series to you all, and we hope that you'll join us on November 1st for part 2 of the series. Please take care of yourselves and have a lovely rest of your day. Thank you.